Good morning, everybody. Today, our topic of discussion is Wilson's disease. So, Wilson disease is a broad topic. We will be covering predominantly the neurological aspects, mainly diagnosis and management. So, Wilson disease was first described. The original article was written by Dr. S.A.K. Wilson in Brain, 1912, where he described cases with progressive lenticular degeneration and liver cirrhosis. Let's see the genetics of Wilson's disease. It's a autosomal recessive disorder. It's due to mutations in the intracellular copper transporting ATPase-B. So ATPase, there are two ATPase genes, ATPase-B. ATPase-B gene defects causes Wilson disease. ATP7A gene defects cause Menkes disease. So ATP-B encodes copper transporter. Mutations leads to copper overload and is responsible for transporting copper out of liver. While ATP7A also encodes copper transporter, its mutation leads to copper deficiency. We'll see how it works. So there are over 900 mutations described. So there are a majority are missense, nonsense, or frame shift mutations, and most patients are compound heterozygotes. So the Europeans have a different mutation, Asians have different mutation, common mutation. Indian scenario, if you see, Indian families affected, there is a wide spectrum of mutations despite the high ranges of consanguinity. So this is the PC27 is the common mutation in western part, eastern part, other mutation. So studies have been done from our institute also. So predominantly from hepatology. So they have found this is one paper published in 2006. 27 patients. So out of this, 22 found, 13 were homozygotes and 9 were compound heterozygotes. One more study has been published recently, 2022. So they used a multiplex PCR-based gene sequencing. So this is the patients which they have found. Right. So pathophysiology, how does the mutation occur? So before that, we'll see the copper metabolism. So copper is absorbed from the stomach and duodenum, and copper enters the enterocyte cells via this copper-specific transporter, CTR1. So once inside, it is the chaperone proteins COX, which binds the intracellular copper. Now, once inside the enterocyte, intracellular copper can be either bound to this metallothionein for intracellular storage, or it can be incorporated into copper-containing proteins, or it can be targeted to extracellular transport through the trans-Golgi network. So, by binding to this ATP7A protein, targets the copper entry into the trans-Golgi network. So ATP7A is the protein which is in the Menkes disease. So from there, after its copper is bound to ATP7A, it is targeted to the trans-Golgi network, and the intravesicular copper is targeted by ATP7A to cell membrane for exocytosis into the portal blood. Now, once in the blood, it is weakly bound to albumin. Now, what happens in the hepatocytes? So, copper is absorbed through stomach, duodenum, epithelium, enters portal circulation bound to circulating albumin. And again, it enters the hepatocytes via copper specific transporter CTR1. And again, same chaperone proteins, ATOX1 is there, which binds intracellular copper. Again, in the hepatocytes, intracellular copper can be bound to metallothioneins incorporated into copper containing proteins, or it can be transported out of the cell for extracellular transfer through the trans-Golgi network. So similar to the ATP7A copper protein in the enterocytes, this is the ATP7B protein in the hepatocyte. So binding of copper to the ATP7B targets copper for extracellular transport into the bile. Also targets masks the copper for binding to apoceruloplasmin to form ceruloplasmin. So what happens in ATP7B mutations? So the mutations prevent copper from being transferred to ceruloplasmin within the trans-Golgi network, prevents copper from being transported into the bile, leading to injury to hepatocytes, and causes weak binding of copper, leading to copper deposition in the brain and other tissues. So this is what happens. So as a consequence of these ATP7B mutations, target copper, this extracellular transport is affected. So secretion of copper into the bile is affected. Secretion of copper binding into the ceruloplasmin is also affected. So these two are affected. So what happens is that copper emerges from intracellular hepatocytes, which are bound loosely to the circulating albumin. So this free copper can be deposited in the tissues of the body. Right. So just a slide on liver involvement. Liver involvement in Wilson disease, incidence is about 40 to 50%. It can vary from asymptomatic to cirrhosis to even liver failure. So liver disease typically precedes neurologic and psychiatric manifestations. Now coming to the neurological features proper. So if you look at the brain pathology in Wilson's disease, there is dramatically increased copper content in the basal ganglia and the cortex. So main lesion is located in the middle zone of the putamen nucleus. As the disease progresses, putamen becomes brownish yellow in color, becomes atrophic, shrunken, and cavitation also occurs. I mean, apart from the putamen, other areas cavitation can also be found in thalamus, subthalamic nucleus, red nucleus, dentate cerebellar cortex, and also in the white matter. So this is the cut section of brain of a patient with Wilson. So you can see there is this is the putamen. You can see the cavitation inside the putamen. Now, histopathological changes can be neuronal loss, spongiosas, cavitation, demyelination, gliosis, etc. So these findings mainly seen in basal ganglia, thalamus, brainstem, cerebral white matter, but are most prominent in the putamen. So coming to neurological symptoms. So neurological Wilson's hepatic Wilson is 1 decade earlier. So but neurological Wilson is in the age group of 20 to 30. Insidious progression over 3 to 36 months. So symptoms, the main presenting symptoms are dysarthria, dysphagia, psychiatric and cognitive decline. But what brings the patient to the doctor is the variety of movement disorders. Can be tremor, dystonia, bradykinesia. In young children, early or subtle neurological manifestation in the form of deterioration of handwriting, scholastic performance, dysarthria, and drooling on saliva. So this is one of the studies done in 2010 showing the percentage of presenting neurological symptoms. Tremor 50%, dystonia 58%, dysarthria 79%, Parkinsonism 30%, chorea 12%. Right. So let's come see the so tremor in Wilson's disease. This is the most characteristic neurological symptom. So it is the first clinical manifestation in 55% of Wilson disease with neurological symptoms. It can many phenotypes, can be resting tremor, postural, most often with the wind beating features, can be kinetic tremor. So this tremor in Wilson disease can resemble essential tremor, dystonic tremor, rubral tremor, and where rarely even Parkinsonian tremor can be mimicked. So can be unilateral or bilateral. So as the disease evolves, the tremor also evolves. So initially, the tremor can be in the form of an essential tremor in the distal upper extremities, less severe involvement of head, legs. So as the disease progresses, the tremor amplitudes, there is progression of tremor amplitude manifests with cerebellar and rubral features. The most characteristic tremor in Wilson's is the wind beating tremor. So it is a posture-induced tremor appearing after 30 seconds, involves proximal part of upper extremities, irregular, large amplitude, and it's very disabling. Severe tremor can completely disable the patient. And tremor in the absence of dystonic component is amenable to treatment. We can treat the underlying tremor. I'll show you one video. So for the first years and all. How a wing beating tremor looks like, we can see. So this is the classic. It appears after latency, proximal high amplitude tremors, classic wing beating tremor. There's another video from the archives of movement disorder.
Bringing him a little closer to his body. Is there a position where there we go? It's all the way extended. Yep, so the back and on. Now hold the hand. Lightly. Let me move my hand away. Just okay. Hold there.
One more video.
This tremor has been maintained and the quality of life is improved at 7 months after thalamotomy. Segment 1 shows severe tremor of the hands and a wing beating type before the left thalamotomy.
Thalamotomy.
There is complete cessation of tremor on the right hand and a significant improvement of tremor of the head and ipsilateral hand 2 hours after thalamotomy.
So coming to dystonia. So dystonia is also a disabling feature. It's reported in 11 to 65%. Usually has coexists with tremor. So prevalence during the course of 38 to 65%. Now dystonia in Wilson can be focal, segmental, multifocal, or generalized. So dystonia is the primary source of neurological disability. What disables the patient primarily is dystonia. So it's severe and mostly it is treatment refractory. The most common dystonic presentation is the abnormal facial expression with an open mouth smile and dystonic drop jaw. This is the vacuous smile. They also have a fixed smile due to the dystonic spasm of the risorius muscle. This is known as risus sardonicus. So this is the characteristic facies you see in Wilson. This is vacuous smile, dystonic jaw, open jaw, risus sardonicus. It can be focal dystonias affecting the neck, hands, tongue, legs, can affect respiratory muscles. In advanced cases, dystonia usually becomes generalized, and this generalized dystonia is associated with high mortality. The focal dystonia seen in Wilson's. Relatively refractory to treatment. So in Wilson disease, there is a decrease of dopaminergic D2 receptors. So they become overtly sensitive to typical dopamine blockers, and they are also prone to develop drug-induced dystonias. So most of them will have some psychiatric manifestation if they are given typical dopamine blockers for some time. Some reason they are prone to develop drug-induced dystonias.
When did this problem first begin?
See one video.
Started getting big, swelling in my ankles, in my ankle.
She uses a sensory trick. Now, Parkinsonism can also be seen in Wilson disease. We recently had a patient with Wilson who presented as a Parkinsonian syndrome. So it can be the first neurological manifestation in 19 to 62%. Involves hypomimia, bradykinesia, micrographia, shuffling gait, cogwheel rigidity. So typically rest tremor, rigidity are asymmetric. So that take home point is that we should evaluate for Wilson disease in patients with early onset Parkinson's disease. Now, patients Wilson's disease can also present with ataxia. First manifestation around 30% of patients. Cerebellar signs, speech. Now, ataxic form of Wilson disease can represent multiple sclerosis. Though this form is also called the pseudosclerotic form of Wilson's. So we see an ataxic gait, micrographia, intentional tremors, dysdiadochokinesia. Nystagmus is rare in Wilson's. So chorea can also be seen in Wilson's, 6 to 16% patients. Now, dysarthria, even though the movement disorders are the what brings the patients to the doctor, but the predominant symptoms will be dysarthria, dysphagia. Dysarthria appears to be the most frequent neurological symptom. It is the first neurological manifestation around 46 patients. It can be seen in around 97% of patients. Typically precedes tremor and dystonia. Dysarthria can be the result of basal ganglia lesion, cerebellar lesions, UMN. So based on the type of dysarthria can be classified as mixed, ataxic, dystonic, hypokinetic, spastic. In some advanced cases, we can even have complete anarthria. But dysphagia is also seen in Wilson disease. It's a classic neurological symptom. Occurs in up to half of all patients. Now, drooling is also seen classically. Swallowing dysfunction or a facial dystonia appears to be the principal cause. Gait and posture abnormalities are reported in 44 to 75%. Usually can be due to extrapyramidal and cerebellar symptoms. So in a 2015 study, they found a high frequency of gait disturbances, 59%. Most common is ataxic, mixed 25%, Parkinsonian gait 18%. 35% of patients have falls. It's a showing the truncal dystonia, postural abnormality. Now, epilepsy is also seen in Wilson's disease. So it has been documented in a study 6.2% of patients can have epilepsy. Can be generalized seizures, partial seizures, can also have a status epilepticus presentation. It occurs at every stage, but most often it is seen after the chelation therapy has been started. Now, advanced stages, you have cortical atrophy, neuronal loss, gliosis, and these may act as an epileptogenic foci. So when we are selecting anti-epileptic drugs for Wilson's disease, so we should take two factors into account. We should not give hepatotoxic drugs like valproate, and drugs which worsen cognitive and behavioral effects we should avoid. Now, other neurological features can be seen: tic, myoclonus, sleep disturbance, autonomic dysfunction. Now, some signs are rare in Wilson's disease. UMN signs are rare. Extensor plantar clonus, rare. Dysmetria, chorea. Cranial nerve deficits are rare. Peripheral nerve, PNS involvement and skeletal muscle involvement is also rare in Wilson's disease. Now, eye signs are also important. KF ring, as we all know. So it was described by Kaiser and Fleischer. Usually occur bilaterally. They have a brown, green, or yellow color. Is visible as peripheral pigment deposition at the Descemet's membrane. So formation this starts in the superior aspect of the cornea, followed by the inferior aspect, and eventually the ring is closed on the lateral and medial aspects. In early stages, we need slit lamp for detection. Later stages, it can be seen by casual inspection. Now, during appropriate treatment for Wilson disease, KF ring can even disappear. It starts fading initially from the lateral and medial aspects and finally from the superior aspect of the cornea. So it is present in almost all patients with a neuropsychiatric presentation. 50% of patients with hepatic presentation, you can have KF ring, and 20 to 30% of pre-symptomatic patients can also have a KF ring. Another manifestation is sunflower cataract. Now, apart from the neurological symptoms, psychiatric symptoms are also a very important feature in Wilson's. Is the presenting symptom in approximately 25 to 65%? The psychiatric symptoms usually presents insidiously as change in personality, behavior, affect. Less frequently can have cognitive changes, anxiety. True psychosis is rare. So we should consider in a patient with less than 30 years of age with a new onset progressive psychiatric disturbance, Wilson's disease should be considered, especially if there is associated by dysarthria or associated with any movement disorder. So usually for this, they will be treated with some typical antipsychotic tend to develop drug-induced dystonia. So that is a pointer towards the underlying diagnosis. Now, a typical psychiatric neuropsychiatric disturbance is the most common initial manifestation. No particular behavioral syndrome is characteristic. It has been described in all stages of Wilson's disease. The average time between psychiatric symptoms and diagnosis is around 2.4 years, while it is 1.5 years for neurological Wilson disease and 0.5 for hepatic disease. Mood disorders prevalent 4 to 47%. Depression is often described in the beginning of the illness. You have high prevalence of bipolar disorder. Anxiety is seen in 20 to 62%. 8.7 can have panic disorders. Psychotic symptoms are rare. One study, 11% patients met the criteria for schizophrenia. So typical presentation is a patient with psychotic symptoms, started on antipsychotic medications, developed significant neurological symptoms, interpreted as being side effects related to antipsychotics. Sleep disturbances can also be seen. Now, other psychiatric symptoms, irritability, impaired social judgment, disinhibition, belligerent behavior, incongruent behavior, personality changes, etc. can be seen. So due to these atypical presentations, the correct diagnosis is most often delayed. So as we seen, though it usually evolves. Initial will be maybe some depression, dysarthria, slow gait. Later on, the movement disorder, tremor, rigidity, etc. develop. The neurological presentations they have classified into 3 types: pseudo-Parkinsonian type, pseudo-sclerotic type, and dyskinetic type. Now, apart from the liver and the brain, other organs are also involved in Wilson disease. Osteomuscular involvement can be arthralgia, arthritis, osteoporosis, osteomalacia. Hematological involvement is also common. Thrombocytopenia. Then renal involvement, renal stone, renal tubular acidosis, etc. can also be seen. So early recognition is important because it is a potentially treatable, reversible disease. We should have a clinical diagnosis, clinical suspicion. So we should consider Wilson disease in all patients, unexplained or atypical neuropsychiatric disturbances, unexplained progressive dysarthria, dysphagia. All patients with undiagnosed movement disorder, atypical Parkinsons, dystonia, bradykinesia, tremor, chorea, patients with involuntary movement. So all these scenarios we should consider Wilson's disease. So guidelines, some guidelines have been for Indian scenario by Indian Movement Disorder Society of India is there, and then Liver Society, Pediatric Gastroenterology. So they have all made guidelines for Wilson's disease. So based on evidence, neuropsychiatric manifestations can be the sole presenting or clinical symptom. The level of evidence and strength is given. So how do we, are there any clinical scales by which we can follow up Wilson's disease? So there is a scale called Global Assessment Scale. It has 2 tiers, tier 1, tier 2. Tier 1 sees the liver, 4 domains are there: liver, cognition, behavior, motor, osteomuscular. Tier 2 has 14 characteristics: Wilson facies, scholastic performance, depression, psychosis. We will see one of the examples. So if you look at tier 1, you can see L, C, M, O. These are the tier 1.
Case 5 illustrates that the GAS for Wilson's disease is sensitive and tracks treatment response. Case 5 illustrates that the GAS for Wilson's disease is sensitive to clinical change and tracks treatment response.
Tier 1, tier 2, 2 tiers are there. We'll come to the. So Neuro Imaging is also important in the diagnosis of Wilson disease. Brain MRI has characteristic features which are seen in about 90% of patients. So brain MRI changes are also seen in about 42 to 70% of hepatic patients, and around 20% of pre-symptomatic patients can also have MRI changes. So as we saw in the pathology, the MRI changes are also localized to the basal ganglia, putamen, globus pallidus, caudate, thalamus, midbrain, pons. Putamen changes may be associated with dystonic features. Thalamic changes may be associated with tremor, ataxia. Changes may be associated with Parkinsons. So this is the classical T2 hyperintense changes seen in the putamen, caudate, and the thalamus. Brain, midbrain, pons. So there are some characteristic features which is rare, not so common. One is the face of giant panda. That is the hyperintense signal which surrounds the red nucleus and substantia nigra with hypointensity of the superior colliculus. This is the face of the giant panda sign. Also, you can have face of miniature panda in the dorsal pons. I don't know how to describe this. So also we can see involvement of cerebellum, corticospinal tracts, and white matter, which can be seen in advanced cases. So they usually will have a T1 hypointensity. White matter changes can also be seen in Wilson disease, typically found in very severe disease, patients with epilepsy, myoclonus. They have a poor outcome. MRI can also be used for monitoring recovery in patients with Wilson. So this can regress on treatment. So this first is before treatment, second is 2 years after liver transplantation. So coming to diagnosis of Wilson disease. So diagnosis of Wilson disease depend on clinical suspicion. So progressive neurological psychiatric disorder, features of dysarthria, extrapyramidal syndrome, cognitive disturbance, personality changes, and we have to look for a KF ring. So what are the tests, routine tests, which can help in diagnosis of Wilson disease? What we do is serum ceruloplasmin, which is typically decreased to copper, which what we are expecting is increased 24-hour urine copper more than 100. Free copper we have total copper, but total copper does not have much of a role. We can, if we have facilities to assess free copper, which can be done. Liver biopsy to look for the hepatic copper, and also KF ring by slit lamp examination. Now there are some pitfalls in diagnosis. Ceruloplasmin less than 10 is diagnostic. We can more intermediate levels like 10 specific can be seen in both patients and heterozygotes. Now up to 15% of patients with neurological presentation can have normal concentration, normal ceruloplasmin. So ceruloplasmin is it helpful, but cannot be relied in all cases. 24-hour urine copper can be false negative in those who are asymptomatic, and it's difficult to perform. We don't know how they are collecting. So completely how much to rely on these values. So we can also do a deep penicillamine challenge test. So after a baseline 24-hour copper, we can give deep penicillamine 2 doses 12 hours apart and look for the 24-hour copper. So look at evidence, ceruloplasmin less than 10 strongly favors diagnosis. Borderline level do not exclude diagnosis. 24-hour copper more than 100, very useful diagnostic test. So in asymptomatic siblings, we can use lower levels. More than 40 can be used for diagnosis for asymptomatic siblings. Deep penicillamine challenge is no longer used because of the high false positive. Serum total copper has no role in the diagnosis of Wilson disease. So tests which are helpful but inconclusive: serum ceruloplasmin, serum copper, total copper. They are helpful but inconclusive. Very helpful test is increased 24-hour urine copper. Gold standard is liver biopsy. And of course, genetic testing, ATP7B gene mutations. So coming to the treatment of Wilson disease. Goal of treatment in a symptomatic patient is to restore normalcy, that is stability, stabilize liver disease, and ensure continued normalcy. Goal for a pre-symptomatic patient is to prevent symptom onset. So treatment phases, there are two phases, initial phase and maintenance phase. The initial phase aims to reduce the body copper levels to subtoxic threshold. So in this initial phase, the choice of treatment, it's a controversial topic. Many centers use chelators alone, D-penicillamine, trientine. Some centers use a combination of chelators and zinc. Some centers even use zinc alone. D-penicillamine has traditionally been the drug of choice, unless the patients develop intolerance, in which the trientine is the preferred drug. Maintenance therapy, it's a lifelong treatment. It prevents further copper reaccumulation after the patient has been effectively decoppered. Now, zinc is very good for that, good efficacy, low toxicity. So it's a drug of choice in a maintenance phase. D-penicillamine can also be used in low doses. So penicillamine, trientine, zinc salts, these are the main treatment. So initial intensive phase, 1 to 2 years for decoppering. And can I take up to 3 years in patients with severe neurological disability? So how to go about this treatment? So treatment strategies, start low and go slow. So we should start the D-penicillamine low doses, preferably 250 on alternate days for 2 weeks. Then we can go up to increase by 250 milligram daily. We can increase by 250 milligram up to a maximum dose of 1000 to even to 2500 mg. So food decreases the bioavailability of D-penicillamine. So it must be administered while fasting. So it is best administered in 2 divided doses, preferably 3 to 4 hours before meals. So first dose can be taken early in the morning. Second dose we can give either midway between lunch and dinner or a few hours after dinner. So D-penicillamine should be supplemented with pyridoxine, 20 milligram of pyridoxine per day. Now, the controversy whether to give D-penicillamine alone or D-penicillamine with zinc, because both it can chelate. If we give, we don't know how the patient is taking. They may take both D-penicillamine and zinc together, so it can chelate. The effect of both the drugs can be neutralized. So many experts in this field give only D-penicillamine. Chelating therapy during the intensive phase. So iron and calcium supplements should also be avoided while during the intensive phase. The maintenance phase is once the copper has been depleted, and once the copper goes out of the body, there will be neurological recovery and there will be stabilization of liver impairment. So we can give either low dose of penicillamine or zinc. Zinc 3 times a day, 50 mg zinc acetate. We can give 50 mg 3 times a day. The most important thing is monitoring of treatment. So objective clinical assessment are better able to track treatment benefits, disease progression, rather than using free copper 24-hour copper levels. Objective clinical is the best way to monitor disease. So global assessment scale for Wilson disease is the preferred scale. So we should use the scale at the start of treatment and then preferably weekly or bi-weekly intervals. In most patients with significant neurological disability, the global scale GS will be stable and gradually will improve over years. So this is how the scaling global assessment scale looks like. So we can have tier 1, tier 2, and the neurological manifestations are scored. So you can see there is a total score of tier 2 has a total score. So we can see the patient improving clinically and also by the objective scale. Now, if we are giving adequate treatment and the global assessment scale worsens, then it can be disease progression, or it can be paradoxical neurological worsening, or it can be due to non-compliance to treatment, or it can be due to an intercurrent illness. So paradoxical neurological worsening is one problem with chelating therapy. Most often, it is seen after treatment with depenicillamine, but can also observe with. So it is reported in around 23% patients, can be seen with a mean delay of 2.3 to 1.9 months. This can be reversible. The paradoxic neurological deterioration can be reversible in around half of cases. More common in patients with higher baseline neurological severity, more thalamic and brainstem lesion, and concurrent use of antipsychotic medication. So what it usually manifests with abrupt clinical deterioration over how to manage this neurological worsening. This is also controversial. Some people advocate continuation of therapy. Some people say advocate down titration of the decoupling doses. So whatever the approach, most studies show that except in a minority, neurological worsens reverse with continuing treatment or temporary interruption of treatment. So once it has reversed, then we can gradually re-escalate the drug doses slowly. No, so once we keep on treating, we can see that the global assessment score stabilizes, improves, and then stabilizes. So it takes up to 1 to 3 years. KF ring can also disappear around 12 to 18 months. So once the copper decoupling is occurring well, general well-being improves, growth improves. So patients can be switched to maintenance therapy. So we can also, most important is the clinical assessment. We can also use urine copper also. Initial treatment should be more than 500. Maintenance treatment, it should be between 200 to 500. The consensus guidelines also recommend the global assessment scale for follow-up of treatment. So apart from the chelating therapy, symptomatic treatment of each symptoms are also, neurological symptoms are also important for the patient. Dystonia is the most disabling symptom. So focal dystonias, we can use botulinum toxin. In multi-segmental or generalized dystonia, we can give anticholinergics, baclofen, benzodiazepines. Dopaminergic agents should every Wilson disease patient with dystonia, rubral tremor, or Parkinsons. If pharmacotherapy is ineffective, we can try deep brain stimulation. Tremor also, management of tremor, we have to correctly classify the tremor so as to give the appropriate treatment. So we can give beta blockers, benzodiazepines, levodopa, anticholinergics, botulinum toxin. So if the tremor mimicking essential tremor, beta blockers are the best treatment option. Propranolol beta blockers, then primidone also we can give. Beta blockers have additional benefits. It has positive effects on portal hypertension. Primidone, low doses should be used because of toxic barbiturate accumulation is a problem. Dystonic tremor, botulinum toxin we can be used for dystonic head, jaw, and voice tremors. Can also be tried medical management. So rubral tremor usually refractory to pharmacological treatment. We can try a high dose of levodopa, anticholinergic, benzodiazepine, levetiracetam. Parkinsonism in Wilson disease has a variable response to levodopa because of the both presynaptic and postsynaptic defects. And also we are giving pyridostigmine, increases the bioavailability of levodopa. So these two, we should not give both levodopa and pyridostigmine together. So all patients with Wilson disease, we should give a trial of levodopa. Amantadine can also be tried. If has chorea, then tetrabenazine can be tried. Seizures standard. So only we should not use drugs which causes hepatic dysfunction and antiepileptics with first pass metabolism in the liver. Along with that, physical therapy, occupational therapy, speech therapy, and if patient has severe dysphagia, then PEG also is a temporary option till the dysphagia improves. So long-term outcomes, 42% can become asymptomatic, 26% can improve residual symptoms, 18% can have long-term disability, 8% mortality can be there. Indian scenario, 6 to 8% can have mortality. Family screening, apart from the treating the symptomatic case, family screening is also very important. Siblings can have a 25% chance of developing the disorder. So siblings has to be screened with 24-hour urine copper and the ceruloplasmin levels. In the child of a patient with Wilson disease who are non-consanguineous, there is a low possibility. The possibility of having Wilson disease is low. If you find a genetic mutation, ATP7B mutation in the patient, then we can test for the same in the siblings also. Any questions?
This symptomatic